Understanding the common patterns and presentations of closed globe injury in a given population helps to improve preventive strategies, optimize treatment protocols, and reduce the overall burden of trauma-related vision loss. Aim of my study was to assess the common modes of closed globe injury and to assess the common presentations of closed globe injury among patients attending our department and materials and methods. The present prospective study was done at our department from June 2024 to May 2025. Inclusion criteria: patient with closed globe injury presenting to ophthalmology department, and exclusion criteria: patients under the age of 6 years and patients with polytrauma incapable of cooperating for study. Consent will be obtained from patients after selection of cases for the study, and patient's demographic data is noted that includes age and gender. Then detailed history is taken, which includes mode of injury, presenting complaints, duration of complaints, and clinical profile is recorded, which includes best corrected visual acuity, color vision, contact sensitivity, and intraocular pressure. Patient then undergoes detailed anterior segment and fundus examination, and data will be entered in Microsoft Excel and analyzed in SPSS software. Results: in our study, we got that most of the injury occurs in the age group between 45 to 60 years, out of 55 with a frequency of 18 and a percentage of 32.7. And in our study, we got males are more commonly affected. There is a frequency of 38 out of 55 and percentage of 69.1. And most common mode of closed globe injury was workplace injury. Out of 55, 23 patients presented with workplace injury and a percentage of 41.88, followed by household injury 11 frequency and percentage of 20%. And in this graph, we can see that in workplace injury and sports injury, most commonly it is affected in males, and household injury, most commonly it affected in females. And the common presentation of closed globe injury was traumatic uveitis. Out of 55, 40% of patients came with traumatic uveitis and 72.7%, followed by commercial retinae 25 and percentage of 45.5%, and followed by lamellar laceration 20 and percentage is 36.4%. And common presentation of best corrected visual acuity was in the range of 6/12 to 6/18. With a frequency of 32 and percentage of 58.18%. And most commonly, the poor visual acuity at the time of presentation was associated with workplace injury and sports injury. Discussion: ocular trauma is one of the most common causes of unilateral vision loss. In our study, out of 55 patients, 61.91% were males and 30.9% were females. And this is probably due to increased exposure of males to road traffic accident and workplace injuries, and many studies have shown the similar results. The incidence of ocular injuries were high in the age group between 45 to 60 years, and this is probably due to increased work-related exposure in this group. The most common mode of injury was workplace injury, followed by household injury, sports injury, RTA, and assault. According to study conducted by Ajay M. Tamevar et al., common mode of injury was also occupational injury. The most common presentation was traumatic uveitis and followed by commercial retinae, then lamellar laceration, hyphema, and retinal detachment and choroidal rupture. Sports injury and workplace injury leads to poor visual acuity at the time of presentation. Conclusion: closed globe injuries were more common in males, and it is more common in the age group between 45 to 60 years. Most commonly occurs at workplace, highlighting the critical gap in occupational safety practices and inadequate use of protective eyewear. Public awareness about wearing protective goggles, face shields, and early interventions can effectively reduce the number of ocular injuries and its related ocular comorbidities. Thank you.
Probably any study will have flavor if it is connected to intervention. Like you have a spread of injury, we'll be more interested in knowing how far they reached the hospital, when was the intervention timed, whether it could be done within the first 2 hours, then how much outcomes were generated in your cohort. Like you are saying, no, workplace injuries this much, that much, how much of visual recovery could be done, how much when ended up with poor vision. That kind of perspective, you are adding it in the conclusion, but
Yes,
you are saying effective intervention is very good in these cases. But that conclusion has no value because you haven't touched upon it in the study. So try to look at it from that perspective from whenever you do a further study. Okay.
Thank you, sir.
Okay, in the household injuries, what was the gender bias? In household injuries, was there a gender bias noted?
Yeah, ma'am. Females were more commonly affected.
Yeah, that needs to be highlighted too. Okay, and in workplace injuries, most of them are medical legal cases. So we have all that noted down, and all that is also important. Okay.
Is it okay, sir? Thank you.
Next presenter is Dr. Shiva Manoj.
Good morning, all. I'm Dr. Shiva Manoj, and I'm here to present Spirochete within the Grave, a case series of leptospiral panuveitis in southern Kerala. These are the contents. Our aim is to report 2 rare cases of non-granulomatous panuveitis secondary to leptospirosis in middle-aged male patients and to raise awareness about such an uncommon manifestation of this endemic disease that is endemic to a frequently flood-affected state. Ours is a hospital-based retrospective descriptive study of 2 different cases of leptospiral panuveitis, and medical records from 2023 to 2024 were reviewed to collect the data. On to the results. The first case is of a 62-year-old male patient who presented with redness, defective vision, and diffuse pain in the right eye. He had past history of similar symptoms in the same eye, which was treated topically. The right eye showed conjunctival and circumcorneal congestion, fresh fine keratic precipitates along with few pigmented keratic precipitates, anterior chamber reaction of 4 plus cells and flare, fibrinous exudate covering the pupil, and the pupil was myotic and sluggish with segmental posterior synechiae, and also on dilated fundus examination, grade 3 vitreous haze was present. Left eye was within normal limits, and he was diagnosed with recurrent non-granulomatous panuveitis right eye. This is a B-scan image of the right eye showing membranous vitreous exudates. Uveitic panel of investigations were sent in this patient, but were inconclusive. So leptospiral IgG and IgM antibodies were sent as the patient revealed a history of catching and killing mice with bare hands, and it came out to be positive. Patient didn't respond to the conventional uveitis management, and started responding only once the anti-leptospiral treatment was initiated. He was treated with systemic and topical steroids, cycloplegics, and other supportive measures for 6 weeks, within which the drugs were tapered and stopped. And he was followed up for a period of 1 year, within which he had no recurrence of the disease. And the second case is of a 67-year-old male patient who had similar symptoms and presentation but in both eyes, and except for a history of fever, tiredness, and vomiting. And he was diagnosed with bilateral non-granulomatous panuveitis. Uveitic panel of investigations were inconclusive. We sent leptospiral IgM antibody in view of high-risk rodent exposure in the past, and anti-leptospiral treatment was initiated after positive results, and he was also treated similarly. Treatment outcomes were completely satisfactory in both the cases. So both the cases were reported to the district health authority immediately after laboratory confirmation, and further actions were initiated. On to discussion. Ocular involvement in leptospirosis ranges from 3% to 92%, and it varies from subclinical to potentially blinding panuveitis. Conjunctival suffusion is typical, but immune phase may show subconjunctival hemorrhages, uveitis, optic neuritis, or retinal vasculitis. Ours, being a frequently flood affected state, has approximately 1.99 million agricultural laborers and has reported 1590 confirmed leptospirosis cases and 94 deaths till July 2025. And according to the data published by Directorate of Health Services, the number of leptospirosis cases and associated deaths has surged over the past 3 years, with a spike in the year 2024, as you can see. So, leptospirosis being a leading cause of death in our state. In our case series, ocular manifestation was the first to develop in both the cases, thus enabling prompt investigations and early diagnosis. Early diagnosis can lead to disease-specific therapy, prevention of complications, as well as to alert the local population by reporting the lab-confirmed cases to concerned health authority. Our findings were consistent with those of Retina et al., who reported predominant presentation of non-granulomatous leptospiral panuveitis in ocular leptospirosis, Badmanabhan et al., who noted better visual recovery with early corticosteroid use, Yogesh S. Kamath et al., whose cases were also reported from frequently flood-affected areas. Leptospiral panuveitis remains rarely reported nationally, with no prior documentation from Kerala, despite the disease being endemic to our country. We found no previous studies reporting ocular manifestations as a presenting feature, highlights the unusual nature of our observation. Our report aims to throw light upon the more or less neglected part of this endemic disease, which would even be the foremost manifestation of it, and to create better awareness among ophthalmologists and physicians. To conclude, in India, leptospirosis is experiencing a resurgence despite often being overlooked. This case series underscores the need to include leptospiral uveitis in the differential diagnosis for patients presenting with uveitis. Timely collaborative care coupled with a keen eye on patient history can make all the difference in achieving favorable visual outcomes and thereby preventing the misdiagnosis of idiopathic or immune-mediated uveitis. Continued research into immunopathogenesis and long-term visual outcomes are invaluable in refining the management of this re-emerging endemic disease. These are my references. Thank you. No, so they first presented to us with ocular symptoms and signs, and in view of the history, we sent for leptospiral IgM. Sorry, sir. Sir, the first patient had history of catching and killing mice with bare hands, and the other patient also had this high-risk rodent exposure history. No, sir. They came to us only first. The second patient had minor symptoms like fever, vomiting. First patient didn't even have that also.
But leptospira has entered into it. Is it possible to get via through eye?
Yes, sir. If there are any minor conjunctival
No,
tear.
suppose first time leptospira enters your conjunctiva. Is it possible to get systemic problem from that?
Yes, sir.
How is it possible to get conjunctiva getting involved in first time?
Sir, if that polluted water or something, when it enters through the eye, like drowning in the water or bathing in polluted water can lead the leptospira to enter through the eye.
How many days it took for the fever to come down after antibiotics in your case?
So usually leptospiral management is from 7 injection doxycycline for 7 to 10 days.
Okay, thank you.
Just please note the third one is not absent. Fahmida is absent. So the fourth one, Revati, Dr. Revati Ravindra is presenting now. Dr. Revati Ravindra. Who is
Good morning. My topic is impact of diabetes mellitus and obstructive sleep apnea on severity of glaucoma. So my aim is to determine the association between diabetes mellitus and obstructive sleep apnea with the severity of primary open angle glaucoma. The materials and methods. The study design is hospital-based cross-sectional study for 1 year, and the study population include all diagnosed cases of POAG. So the inclusion criteria is patients between 40 and 75 years of age, all diagnosed cases, irrespective of their treatment status and current IOP status. And corrected visual acuity is 660 or better. Typical optic disc changes showing diffuse or localized rim thinning with neuroretinal rim loss, enlarged cupping, peripapillary atrophy, notching and disc hemorrhages, asymmetry in the cup disc ratio more than 0.2 between the two eyes. Then typical glaucomatous field defect as per Anderson's criteria on a reliable field which is done within the last 3 months. The exclusion criteria is history of intraocular surgery except uncomplicated cataract surgery, then regular use of contact lenses, then secondary causes of glaucoma like pseudoexfoliation glaucoma, pigment dispersion glaucoma, use of corticosteroids, previous ocular trauma, then the presence of other diseases that would cause abnormal visual field. Then the study design is hospital-based cross-sectional study, sample sizes 78 patients. Methodology, full medical and ophthalmic history is taken, best corrected visual acuity is done, slit lamp examination done to find out any anterior segment pathologies, intraocular pressure was measured by applanation tonometry, gonioscopy was done to grade the angles, reliable field was taken, dilated fundus examination was done, then assessment was made based on the HFA findings. Then the data was analyzed by SPSS software, quantitative variables expressed as mean and standard deviation, qualitative variables were expressed as proportions, and association was done through chi-square test. Then result, the mean age was 58.77 plus or minus 9.806. So the age distribution is most of our patients were more than 66 years, and the distribution of diabetes and OSA, the positive patients were 38 and those with OSA were 24. Then association with age and glaucoma severity, it showed a p-value of 0.0001 percentage, which is highly significant. Then for diabetes and severity of glaucoma, we got mild cases as 11 patients, then moderate glaucoma 14 patients, and severe 30 with a p-value of 0.042 percentage. That is also significant. Then association of OSA and severity of glaucoma. Those with mild glaucoma changes were 8 people, and with moderate there were 5, and with severe 11 people. And the p-value was 0.01 percentage. It is also highly significant. So moving to the discussion, the mean age of the POG patients were 58.77 plus or minus 9.806, and majority were above 66 years, which was similar to the study done by Al-Majawi et al. And the diabetes mellitus also showed a significant association with the glaucoma severity. So it aligns with the studies done by Pascal et al. And Cavazzi et al. OSA also had a significant association with glaucoma severity, and it aligns with the study done by Shi et al. So, a statistically significant difference was observed between age and the severity of glaucoma. Diabetes and OSA showed a significant association with severe glaucoma, which highlights the potential impact of these comorbidities on disease progression. Hence, these risk factors should be considered while managing glaucoma. So, these are my references. Thank you.
What, according to you, is mild, moderate, and severe glaucoma?
Ma'am, based on HFA findings and optic disc findings, we graded as mild, moderate, and severe.
That should have been more specific there. And how many patients had both diabetes and OSA? And among the patients who had obstructive sleep apnea, what was the severity of OSA? And how do you correlate? What was your
Ma'am, based on stop bank criteria, we took OSA.
No, but there's a standardized AHI index, right? So what was included, what was excluded in that? and how many patients had overlapping diabetes as well as OSA. The mechanism of how these conditions worsen glaucoma varies. So how did you correlate all of this together?
In the study design, you had a flaw. You took two variables and saw how much they'll play on original disease. One of those variables is so very common that it's almost present in all of your patients. The second variable we are associating with another type of glaucoma called normotensive glaucoma. You are bringing it into POAG. So these flaws created a illusion which, Madam pointed out, how much of overlap between these two risk factors were there in a single patient, and in those patients how much progression severity happened. These things you should expose, or else it just becomes like a status report on 30 glaucoma patients. That's all what you're saying. You're not telling us clearly what happens with these risk factors in a particular person and what happens when they compound, both the risk factors compound in a particular patient. Okay? Try to do that. Thank you.
Thank you.
The next presenter is Dr. Mirin Baby.
So, good morning to all. My topic presentation is retinal nerve fiber layer alterations in migraine, a comparative study. Introduction. Migraine, we all know, is a common disabling neurological disorder characterized by recurrent headaches. Its effect on brain structures are very well established. RNFL evidences that it may impact the RNFL layer is also being growing nowadays. So, migraine mechanisms that alter the RNFL is one is vascular dysregulation, other is inflammatory changes. RNFL alterations may act as biomarkers for migraine severity. It is also a risk factor for normal tension glaucoma. OCT gives a precise measurement of the RNFL thickness. Aim is to evaluate the structural impact of migraine on RNFL thickness using OCT materials. It is hospital-based study, descriptive comparative study for the period of 2 months. Patients were aged between 18 to 50 years. Consecutive sampling was done, and the participants were divided into 2 groups, 60 in each. We included all the migraine patients who were diagnosed by a neurologist according to the ICHD3 criteria, with or without aura, and all the healthy controls were also taken without any ocular or neurological diseases. Exclusion criteria, we excluded secondary headache, optic disc edema, patients' structural brain lesions, glaucoma, and retinal pathology. First, we took informed consent followed by detailed history taking. Then, ophthalmic evaluation was done. RNFL thickness was measured using a spectral domain OCT. Results. First is comparison of background characteristics of patients with migraine and normal population. So this is age and sex distribution which is showing. The mean age of migraine patients were found to be 38 plus or minus 11.6, and of controls were 33.8 plus or minus 10.3 years. In both migraine group as well as the control group, predominantly it was females. Coming to distribution of characteristics of migraine among the patients with migraine, that is, we took with aura and without aura, and also the duration of migraine. And we saw that most of the patients who came to our OPD were without an aura, and only 21% had aura. The mean duration who came to our OPD was almost 8 to 6 months, 8 months, and only very few patients came with more than 1 year. This is a comparison of RNFL thickness between patients with migraine and also the control group. Here's another chart representation. We all compared all the 4 quadrants, that is superior, inferior, nasal, and temporal, as well as global RNFL. Thickness was compared between both the groups. And we found that there is a significant thinning that is seen in the RNFL layer in most of the quadrants, especially in the superior and the inferior quadrants of migraine patients as compared to the controls. And this is based on the type of migraine. But in type of migraine showed no significant difference between control as well as the migraine group. And discussion. Migraine is associated with notable structural alterations in RNFL, which reflects the underlying neurovascular stress. The RNFL difference, significant thinning was found in superior as well as the inferior RNFL quadrants. In most of the patients, p-value less than 0.01, suggesting that these regions are particularly vulnerable to migraine-related vascular injury. And quadrant specificity, the nasal and temporal quadrant showed very less, that is, inconsistent differences in both the groups. And based on the aura status, our study showed that did not show any significant difference between migraine with or without aura, which show that aura is not a major determinant in RNFL structure involvement. Overall pattern, superior and inferior RNFL thinning indicates localized axonal loss likely due to recurrent vasospasm. Role of OCT. OCT detects a subtle optic nerve changes even in early migraine. So establishes OCT as a highly sensitive early diagnostic tool. Conclusion, migraine patients showed significant RNFL thinning on spectral domain OCT. Superior and inferior quadrants were mostly affected due to neurovascular vulnerability. RNFL loss was independent of aura and migraine duration. Findings suggest that recurrent vasospasm and hypoperfusion as key mechanisms in retinal damage in migraine patients. Migraine-related RNFL thinning may increase the long-term optic nerve vulnerability, similar to glaucomatous patients. So OCT is a rapid, non-invasive, highly sensitive tool. Future studies can be done combining OCT with visual field testing also to assess the functional disability of the patient. So limitations of our study, as it was a pilot study which I conducted, it was a smaller size sample size and only very short duration patients were included. So we couldn't assess the long-term effects and only RNFL was assessed. No functional testing was done. Thank you.
You're told about aura, no? What type of aura the patient had? Some of your patients, some percentage of aura, no? Aura.
Yes, sir. So actually, they were diagnosed with aura. The patient actually had visual aura symptoms mostly. Most of
type
them
of-
visually and yes, sir.
What type of this thing, visual aura?
So they could see things. They were telling like floaters, maybe lightings, like flashes of light. That was
That is
one of the complaints.
fortification spectra you've seen.
Yes, sir. Like they. So mainly ocular symptoms, ocular aura symptoms, sir.
Those patients didn't have any problem in the.
So actually, with the aura patients, it was a consecutive sampling. So we only got with the aura patients very few in number. So that is one limitation, sir. So we can. So in my result, most of them were without aura. So that is why the result came as without aura. There is no significance. Maybe if we take more patients with aura and if we do the future study, maybe we can find there will be some associations. That is one limitation of my study, sir. Very less sample came with the aura. That's the.
You are a postgraduate student.
Yes, sir. Yes, I'm a postgraduate.
Which college?
Pariyari Medical College.
Okay, can I ask you one question?
Yes, sir. Sure.
What is teichopsia?
Sir?
Teichopsia. Teichopsia.
Sorry,
Because you
sir,
are
I
starting
can't
about talking about migraine. This is some type of viva question will ask you in exams. Of course, doesn't matter about this paper. What is
Not sure.
teichopsia? Teichopsia.
Not sure, sir.
If you tell correctly, Rashidhar, got it? You don't know. The
No,
other
sir,
name
sorry.
for fortification spectra. You are getting, aura. That
Yes,
is
sir.
called teichopsia. Okay.
We appreciate the thought, but as you said, the progression of the RNFL defect we haven't established.
Yes, sir. Yes, sir. It was.
So the association between an RNFL defect, a standalone RNFL,
Yes.
presumed RNFL defect, in a patient who is presumed with migraine. Migraine
yes.
is also not a definitive diagnosis.
Yes. Yes.
I haven't seen neurologists give migraine as a definitive diagnosis. It's just a sort of a wastebasket diagnosis where they couldn't make any other diagnosis, they'll bring to this diagnosis. So those kind of variables are still there.
Yes.
But the thought is correct. At least in these kind of patients where you say that vasospasm is
Vasospasm is
a
major
recurrent
part of
factor,
spectra.
then how much it affects the disc and RNFL is good to see. And obviously do it with field and do it with
Yes, sir, we should-
MFERG
functional
also.
assessment
You
was
can use
needs to be-
MFERG on those spots where
Yes,
you
sir. Yes,
suspect
sir.
the
Yes.
RNFL weakness, and that points can be revealed
Yes, sir.
by that. Good.
Last point.
Yes, ma'am.
In migraine, there is spread of cortical depression. The cortical matter what is affected. So more than RNFL, I presume GCC would be a much sensitive marker
Yes.
in migraine patients. And ideally, whatever the migraine, whatever visual hallucinations, positive or negative, they never cause a permanent visual defect. And I hope you've ruled out all retinal migraines in these patients. Okay? Because their thing can be different.
Okay. Thank you, ma'am.
Let's please now. Srishma is absent, sir. Absent. So we are moving to the next presenter, Dr. Sara Maideen Kunyu. Sara Maideen Kunyu.
A very good morning to one and all present here. I am Dr. Sara. I'm going to present the paper Perception of CBME Implementation in Ophthalmology, which is a dream-based evaluation among medical students. The educational environment strongly influences medical students' academic achievement, professional development, and well-being. As there was a transfer from conventional curriculum to CBME, systematic evaluation of learning climate is essential. The Dundee-ready educational environment measure developed by Prof et al. Is a validated 50-item questionnaire. It is measuring students' perceptions of their learning environment, covering 5 domains with a maximum score of 200. Our aim was to assess undergraduate medical students' perception of their educational environment using 50-item DREAM questionnaire with 8 institution-specific items, that is DREAM Plus. We took a descriptive cross-sectional survey was conducted at Medical College. Data were collected from 2019 and 2022 batches. 70 MBBS students who consented and completed the 50-item DREAM questionnaire and 8 institution-specific items, DREAM Plus. Now we had 5 domains of DREAM. The first domain was students' perception of learning. It was assessing how students feel about the quality, relevance, and effectiveness of teaching or the learning they receive. The domain 2, students' perception of teachers. It is measuring how students view their teachers in terms of teaching ability, communication skills, attitude, feedback, and encouragement. Domain 3, students' academic self-perception. It is reflecting how confident students feel about their own academic abilities, progress, and preparedness for their future profession. And domain 4, students' perception of atmosphere. It reflects how students feel about the overall learning environment or climate, including academic atmosphere, support, stress, relaxation, and interaction. And domain 5, students' social self-perception. It reflects how students feel about their social life and support system, including friends, opportunities for relaxation, support for stress, and accommodation. DREAM Plus includes 8 questions which are specific to ophthalmology trainings, like adequate hands-on training, use of ophthalmic instruments, case discussions, etc. The 50-item DREAM questionnaire was scored on a 5-point Likert scale plus 8 institution-specific items, DREAM Plus, anonymous classroom administration under supervision, and data was analyzed using Excel and SPSS V25. Now, the interpretation, total DREAM score was out of 200, and 0 to 50, very poor, 51 to 100, plenty of problems, 101 to 150, more positive than negative, 151 to 200, excellent. Individual DREAM item mean score was more than or equal to 3.5, strong positive point, 2 to 3.49 could be enhanced, and less than 2 problematic area. And participant demographics, total participants 70 we took, and mean age 23.5, female count 50, male count 20. Now overall DREAM score, we got 127.4. So here the mean total score is falling within 101 to 150, which shows there was more positive than negative. Now DREAM item analysis domain wise. So domain 1 was focused on students' perception of learning. So here we had a mean more than 2, but we were highlighting a key problematic area on active learner encouragement, where mean was less than 2. Then domain 2, which was focusing on students' perception of teachers. Here highlighting a problematic area on teacher behavior and feedback, where mean was less than 2. Domain 3, focus on students' academic self-perception. We scored mean more than 2. Coming to focus on students' perception of atmosphere, that is domain 4. Here we were highlighting the deficit in interpersonal skill development, where mean was less than 2. And also in the stress and fatigue part of students' perception of atmosphere. Coming to social self-perception, that is domain 5, we had mean more than 2. So overall domain score, we got social self-perception with the maximum 67%, which shows a strong peer support and more positive than negative. And coming to students' perception of teachers, it was 64.3%, again more positive than negative, which is showing a positive faculty review. And academic self-perception was 62%, which showed room for improvement. And students' perception of learning, again 61.4%, room for improvement. Perception of atmosphere, 60%, which had plenty of problems. Now coming to DREAM Plus item analysis, which was specific to ophthalmology, we scored mean between 2.86 to 3. And item total correlation were more than 0.74. That was suggesting excellent internal consistency and very high relevance. So I can conclude by telling that educational environment was perceived as more positive than negative by undergraduate medical students. And we had strong peer support and favorable views of faculties. Areas of improvement was in academic atmosphere and learning methods. So the additional Dream Plus items were also well received, indicating relevance to local academic needs. So findings here align well with the recent Indian studies and highlights the potential impact of integrating CBME aligned elements like mentoring, timely feedback. Continued efforts towards student-centered teaching, wellness support and curriculum refinement are essential. These are my references. Thank you. Yes. Sir, ophthalmology, I was taking mine was, yeah, sir. Sir, we were taking the study as a whole. Uh, yeah, sir, medical colleges only. This, sir, I didn't get you. Oh, okay. Okay. Oh, yes. Ye- Um, uh, yeah. Yeah, ma'am, actually the study was from 2019 and 2020 batches. So the questions were not ophthalmology was only based for the training. We took separate Dream plus 8 questions. Rest of the questions uh, were common. Like it's not specific to ophthalmology, but all, yeah, overall, madam. Uh, yeah, yeah, sir. Yeah, it was good, sir. Sir, actually, when during our days, it was more traditional. Like, it was not CBME. So I felt I can see the differences. Like when now students come to our OPD, mainly now I'm in ophthalmology department, so I can see how the CBME has changed them. Like because they started using more. It is more. Uh, Case-based studies, or they started using the instruments, and I can see that confidence in them, sir. So I think if it was there for us also, it would be better. I felt because I can see the difference, sir. Like when it was our batch, it was traditional. Like it was more syllabus based. Now I can see it is more. It is students. It is students centered. So I feel yes, sir. It is recently introduced. Yes. Okay. Hmm. Okay. 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 Sir. Yeah. Yes, sir. Okay. Okay. Sir. Hmm. Okay. Sir. Okay. Sir. Thank you, sir.
The next presenter is Dr. Fatimat Suhaira.
Good morning, all. My topic is on non-strabismic binocular vision anomalies in children attending a tertiary eye care center. Why the topic is relevant? It is the second most common optometric condition in the pediatric population. Most of the cases go undiagnosed. It can be largely prevented through the timely identification and appropriate treatment. What is binocular single vision? It is a state of simultaneous vision which was accomplished by the coordinated use of two eyes with the goal that the separate and slightly different images emerging in each eye were appreciated as a single image. Broadly, non-strabismic binocular vision anomalies are categorized into accommodative dysfunction and vergent dysfunction. Accommodative dysfunction include accommodative insufficiency, spasm, infacility, and ill-sustained accommodation, while vergent dysfunction include convergent insufficiency excess, divergent insufficiency excess, basic esophoria, exophoria, and fusional vergent dysfunction. Aims and objectives of the study, it was to find out the prevalence of the accommodative and vergent dysfunction in pediatric population and in various refractive conditions. Materials and method, it was done as a cross-sectional prevalence study at Comtrust Charitable Trust Eye Hospital, Calicut, with a sample size of 366 children between the age of 6 and 12 years. The duration of study was 1 year from May 2023 to May 2024. Inclusion criteria include subjects whose parents are willing to let their children participate in the study, age between 6 and 12 years, best corrected visual acuity of 6 in each eye, unremarkable general and ocular health. Exclusion criteria include any significant perinatal history, taking any topical or systemic drugs, history of neurological or muscular disorders, tropias, done any orthoptic exercise in the past, amblyopia, and history of ocular surgeries or trauma. Methodology, after getting consent, detailed patient history was recorded. Basic ophthalmological evaluation including cycloplegic refraction and appropriate correction was given. Comprehensive binocular vision assessment done including Fourier test for both distance and near, negative and positive fusional vergence using for distance and near with horizontal prism bar, near point of convergence with a Royal Air Force rule, amplitude of accommodation, accommodative facility, negative and positive relative accommodation, vergence facility, accommodative lead and lag using monocular estimation method, dynamic retinoscopy, AC by A ratio using gradient method. The results obtained were compared with the tables of the established expected values by the Sheeman and Beek. Coming to result, of total subjects with 366 sample, 42% is having, that is 154 children is having non-strabismic binocular vision anomalies, while 58% was of normal binocular vision. While finding out the prevalence of each of the non-strabismic binocular vision anomalies, convergent insufficiency was the most prevalent, about 20%. Then come the accommodative infacility was about 7.7%, and coming the combination of the convergent insufficiency and accommodative infacility. Age-based analysis of the prevalence of the binocular vision anomalies in 6 to 8, 8 to 10, and 10 to 12 years shows an increase in the binocular vision anomalies. That's increasing convergent insufficiency in the 10 to 12 years. While finding out the prevalence of the binocular vision anomalies in each refractive condition, among the emmetropes, 45% of subjects have convergent insufficiency, while 21 having accommodative infacilities. Among hyperopia, 52.4% is having convergent insufficiency and 14% had accommodative infacility. In myopia, again the most prevalent was again convergent insufficiency followed by the accommodative infacility. In astigmatism group, convergence insufficiency is the most prevalent, followed by the combination of convergence insufficiency and accommodative infacility. While checking the dynamic retinoscopy in myopia, the independent sample t-test results indicate a statistically significant difference between the monocular estimation method of myopic and non-myopic subject. It gives a strong evidence to suggest that values of MEM in myopic subjects of higher side compared to the non-myopic subject, indicating a lag of accommodation in the myopia. Coming to discussion, as per the band study done in Tamil Nadu in 2017, the prevalence of non-strabismic anomalies of the binocular vision found to be 31.5 and 29.6% in rural and urban populations. Convergent insufficiency was the most prevalent. Again, another study in Taiwan with 589 children of age 8 to 13 years found 28.5% presence with non-strabismic vision anomalies, with convergence insufficiency was the most prevalent. Limitation of the study, it was a hospital-based study, so the results must be used with discretion while comparing to the whole population. Equal number of participants in all refractive condition would have given better result for the comparison of the binocular vision anomalies in each refractive condition. Coming to conclusion, non-strabismic binocular vision anomalies are highly prevalent in pediatric population. Convergence insufficiency is the most common non-strabismic anomaly of binocular vision, followed by the accommodative infertility in the population. While considering the refractive condition, again the convergence insufficiency was the most prevalent. Vision screening protocol designed only to screen for the ocular disorders like refractive errors, congenital cataract will miss a significant number of binocular vision anomalies. So, binocular vision anomalies had a significant impact on the academic performance also. So, comprehensive binocular vision assessment and its screening should be a part of normal vision screening protocol. These are my few references.
We are advising screening. The variables are too many, no? I think 14, your table had 14 non-strabismic binocular vision difficulties. What will you advise as the best three or the most important three which need to be tested in all children? Because obviously refractive checking in children is a difficult thing in itself. So you are going to add a battery of tests or battery of workup to that. Then we'll have to be very judicious, no? So of the 14 or 15 which you listed, which will you say are the most key three tests which we need to add to every child who is being tested? And you'll also have to tell what are the symptoms in those child which will make the practitioner think that there can be this kind of an issue and try to test it further. So those kind of interventional aspects should be added to a study. Only then the study will have more acceptance, more. You are just making it look like an analysis of the issue. Issue analysis is good in a way only when it gives positive ideas on intervention. Okay.
You're told about convergence insufficiency, some of the patients, most of the patients. They have not, they didn't show any type of squint also at any point of time during the daytime or something. Because their insufficiency, naturally they can have sometimes, going, the eyes may go out. Because you're told non-strabismic. Here, some of the convergence insufficient patient might have gone for sometimes at least intermittent type of deviations. Huh?
Including only the tropias, sir. We are including the phorias.
You have not included 4 years.
Including the phorias, excluding only tropias.
Oh.
Constant.
Okay, okay, nice. I can't follow.
The next presenter is Dr. Hridya Dominic.
Good morning to all. Today my paper is on the topic prevalence of ophthalmic disorders in children with and without learning disability, a comparative study. Vision plays a fundamental role in a child's cognitive, social and educational development, and ophthalmic disorders during childhood can interfere with overall learning performance. So this highlights the importance of early diagnosis and management of ocular disorders, especially in learning disability children. And a few of the research studies have shown that children with learning disabilities have maybe an increased risk of ocular disorders than the normal children. Coming to the importance of the study, there are only limited number of studies based on this issue from our state. And aim was to determine the prevalence of ophthalmic disorders in children with learning disability and to compare with the prevalence of ophthalmic disorders in children without learning disability. Objective was to determine the ophthalmic disorders in children with learning disability. Second was to determine the ophthalmic disorders in normal children. And final was to compare the prevalence of ophthalmic disorders in children with learning disability with that of normal children. Coming to the methodology, it was a comparative analytical cross-section study done over a period of 18 months, February 2024 to August 2025, on children between 5 to 15 years of age on a pediatric ophthalmology clinic in CDC in a tertiary care center in Central Kerala. Coming to inclusion criteria of cases, children who was diagnosed as specific learning disability by clinical psychologist, and controls were selected as with no history of learning disability who are attending the school screening program. And coming to the exclusion criteria, it was children with hearing impairment and also parents who do not give willful consent for the study. According to the sample size equation, we derived a sample size of 60 with minimum in each group in case and controls a total of 30 and 30. And consecutive sampling method was used. And in study procedure, a proper informed consent from guardian was obtained. After that, detailed history taking regarding family history, birth history, and development history was done. A systematic ocular examination with emphasis on vision assessment till cycloplegic refraction and fundus examination was done. And dynamic retinoscopy was done using MEM method to assess accommodation anomalies in all children. And on PMT, after 3 days, we were assessing CVA screening also, along with Lia tools and Thathan's inventory type 2. And coming to the analysis, Fisher's exact test and chi-square test was used to assess the variable significance. Coming to the results, a total of 62 children participated in our study, that is 31 in learning disability children and 31 in normal children, and was an age-matched analysis with, as we see here, males made up a larger percentage in both categories in the study. And coming to family history analysis, the learning disability children had more occurrence of ophthalmic-related family history, and significant among one of them was refractive error in the family. And in normal children, there were less occurrence of family history, ophthalmic-related. And coming to birth history, the two study groups differed significantly. 80.6% of LD children and 9.7% of normal children had unfavorable birth history. And these were the statistically significant factors. There was preterm birth, low birth weight, neonatal resuscitation, respiratory distress during birth, prolonged NICU admissions, phototherapy, IVF treatment, and LSES. And these were the statistical non-significant factors. Coming to the developmental milestones, the two study groups differed significantly. That was, learning disability children had more abnormal developmental milestones than compared to normal children. And also, the LD children had 9.7% of history of inadequate immunization also. And coming to treatment history, there were more ophthalmic-related history was more pointing towards learning disability children compared to normal children. And these were my ocular findings. Most common one was the refractive error, and followed by amblyopia. Then the most statistically significant ocular findings seen only in LD children was strabismus, and abnormal fundus findings were seen only in LD children, that was myelinated nerve fibers and temporal pallor of disc, and one child was diagnosed with CVI also. And coming to the refractive error analysis, most common refractive error was simple myopic astigmatism, which was mostly seen among normal children, and the final was simple hypermetropic astigmatism. And previous refractive error correction when compared to LD children, normal children was less, that was 11.76% compared to 31.58%. And second most common finding, amblyopia. Here, bilateral anisometropic amblyopia was the most common NIT. And in 10 LD children and 7 normal children were identified with amblyopia. Coming to the discussion, here in our study, birth history was the most significant history from our study, and similar stomy perinatal history were encountered in referred study by like Gogate et al. Study and Kaleselvi et al. Study. And in inadequate immunization in LD children was correlating with the similar observation in Eric Emerson et al. Study done in UK in 2019. And most common finding was refractive error, and similar findings were seen in other studies also. But second most common finding was different from other studies. And CVA was also identified in our study, and previous refractive error correction was more in our study compared to other studies. Coming to conclusion, majority of LD children had history of stomy perinatal period, and history of developmental delay and inadequate immunization were more in LD children. Prevalence of strabismus was significantly higher in LD children compared to normal children. Normal children had more occurrence of uncorrected refractive errors than LD group, and no significant difference in prevalence of disorders were present late ophthalmic in two study groups. Coming to recommendations, children with perinatal complications should undergo LD screening and regular ophthalmological assessments. And also in normal children, we should give the importance of school screening programs, and also proper parental counseling regarding immunization should be stressed on. These are my references. Thank you.
What were the learning disabilities? What was diagnosed by the psychologist?
Ma'am, we separately diagnosed, sampled only specific learning disability children, ma'am. That was IQ more than 86 only we were taken for the study.
Yeah, IQ, nothing else apart from that.
IQ, Binet Camet method and enhanced battery assessment was done by the clinical psychologist, ma'am.
I think, yes, sir, using the term normal children is not fair. Okay, you can just term it as children without learning disabilities. Normal is a highly variable term.
Okay.
You're told about the sample size, no?
Yes.
Did you understand anything about that? Because you are given so much of formulas and all. No, I know you would want to calculate it also. But the problem is somebody with statistician might have given you.
Yes.
Did you ask him about explanations from for that formulas and all? Not interested. Please remember in examinations, as an examiner, we will come and ask this question only. Definitely you get caught. Okay?
Yes.
That means just try to learn, at least for your recitation. Understand now? You are told about Erie-Bulfron, one case. Erie-Bulfron, no?
Yes, sir.
Did you examine that patient fully?
Yes, sir. I have examined the patient.
Did the patient had some syndromes? You know the name of this? As a PG, I'm asking you questions. Did you know the name of the syndrome for that Erie-Bulfron, sometimes associated? Lips problems and all. I've heard about it. No. At least know one thing called Kabuki syndrome. Kabuki, K-A-B-U-K-I. Kabuki syndromes is there associated with your Erie-Bulfron.
Yes, sir.
Okay. Just, of course, you are a PG only, no?
Yes, sir.
Nothing wrong. You just learn. Okay. Thank you.
Thanks.
That one rejoinder, caveat to what you said. You are saying like refractive errors and everything is more prevalent in the learning disability children. I think it's an illusion because probably learning disability children are more worked up by the ophthalmology team, and just because of that, it's revealing more errors. So the statement that learning disability has more refractive errors, I don't think is valid. And second, when you are comparing that group, then the next group shouldn't be normal children. It should be some other group which will come to check up. For example, you can say like every child which goes before preschool workup, preschool ophthalmic workup, like that, you limit the second group so that it becomes as close as possible to the first group. Only then they'll become oral, they'll become apple oranges. Okay, so the normal children and learning disability children are poles apart, no? So that kind of checking cannot be done.
Thanks.
The next presenter is Dr. Aditya A.
So good morning all. My topic is analysis of visual field progression between pseudoexfoliation glaucoma and primary open angle glaucoma. And glaucoma remains the leading cause of irreversible blindness worldwide, and among its subtypes, primary open angle glaucoma and pseudoexfoliation glaucoma represent entities with distinct epidemiological and pathological features. In primary open angle glaucoma, it is a chronic optic neuropathy with open angle, and pseudoexfoliation glaucoma is a secondary glaucoma due to pseudoexfoliative material deposition. It can be closed or open angle glaucoma. And pseudoexfoliation glaucoma linked with higher IOP, greater diurnal fluctuation and faster progression, and functional assessment via visual field analyzer remains the gold standard. Aim of the study was to compare the rate of visual field progression among patients diagnosed with pseudoexfoliation glaucoma and primary open-angle glaucoma. Visual field index and mean deviation was used for functional assessment and progression analysis using Humphrey field analyzer. It was a retrospective cohort study including 30 pseudoexfoliation patients and 30 primary open-angle patients. An age, visual field index and mean deviation across 3 visits were recorded, and statistical analysis using paired t-test was used to evaluate within group changes and unpaired t-test to compare progression between 2 groups. Inclusion, it was a reliable HFA test for more than or equal to 3 visits, visual acuity more than 6/60, confirmed diagnosis of primary open angle glaucoma and pseudoexfoliation with open angles, and excluded were visual acuity less than 6/60, all other types of glaucoma including pseudoexfoliation with closed angles, insufficient information, history of ocular surgery, diagnosed with uveitis, keratopathy, trauma to the eye, and during the study period no significant lens opacity developed or no surgery was performed which would enhance vision. And by our study, we concluded that pseudoexfoliation patients were significantly older with a mean age of 78.3, and in primary open angle glaucoma, mean age was 69.8 and a significant p-value of less than 0.001. And this is the graph showing visual field index progression analysis. And in pseudoexfoliation glaucoma, the visual field deteriorated from 85.4 to 81.3 and then to 78.4. And within the group, it was a significant with a p-value of less than 0.001. And in case of primary open angle glaucoma, the value diminished from 79 to 77.3 to 75.9 with a significant p-value of less than 0.01. And comparing the intergroup comparison, the p-value was less than 0.001, indicating a significant decline in pseudoexfoliation patients compared to primary open angle patients. And similar curves were obtained for mean deviation progression. This in pseudoexfoliation group, it declined from minus 6.8 to minus 8.3 and then to minus 10.2 with a significant p-value of less than 0.001. And in primary open angle group, it declined from minus 7.7 to minus 8.6 and then to minus 9.9 with a p-value of less than 0.001. And in the group comparison also showed a significant difference of p less than 0.001, indicating a progression in pseudoexfoliation group than the primary open angle group. And pseudoexfoliation patients showed faster progression in both VF5 and mean deviation compared to primary open angle group, and it represents a systemic process associated with increased cardiovascular and cerebrovascular morbidity. Endothelial dysfunction and vascular dysregulation worsen optic damage, and pseudoexfoliative material obstruct trabecular meshwork, which leads to increased IOP. And oxidative stress may play a great role in accelerated progression. And comparing the study with other studies, our study was a retrospective study including 30 primary open angle versus 30 pseudoexfoliation patients, and 3 HFA visits were taken and visual field index and mean deviation progression was checked. And in the study by Ayala et al., it was a longitudinal visual field study comparing primary open angle group and pseudoexfoliation patients, and in Khalil and Gupta study, it was a comparative visual field progression study. And in our current study, pseudoexfoliation showed steeper decline in visual field index and mean deviation. And in study by Ayala et al., annual mean deviation loss in pseudoexfoliation group was minus 0.36 decibel per year versus in primary open angle group it was minus 0.24 decibel per year. And in Khalil and Gupta study, pseudoexfoliation showed more rapid visual field deterioration than primary open angle glaucoma. Now, all 3 studies concluded that pseudoexfoliation progresses faster and has a faster functional decline and require shorter review intervals. It was a limitation. It was a small sample size study, and time period between respective perimetry vary for plus or minus 1 to 2 months among patients, and it relied exclusively on functional testing without incorporating imaging modalities like OCT. And to conclude, PXFG demonstrates significant faster visual field progression than primary open angle glaucoma and emphasizes need for aggressive management and frequent monitoring and management strategies for pseudoexfoliation, including lower IOP targets, earlier surgical intervention, and more frequent follow-up testing. And it also highlights the importance of tailoring treatment approaches according to the glaucoma subtype. and pseudoexfoliation demands lower IOP targets than primary open angle glaucoma. Combination therapy is often indicated at diagnosis, and it requires closer follow-up and earlier surgical consideration, as it is unlikely to control medically. So my references. Thank you.
Variable which leads to progression. If progression is being judged on two cohorts, the variable that leads to progression is adequacy of control. Yes or no?
Yes.
That is not stressed in the study. You have never touched upon what drugs you gave, how many drugs you gave, what target pressure you set for both the cohorts. You never touched upon. You just said that PXF will go. Obviously, a secondary open angle glaucoma will go faster than a primary open angle glaucoma. That is expected. Even if that PXF has been PDS, I am sure the same result would have come. So that way you'll have to slightly change the design so that you look at the variable from the point of context of what you are studying. Okay.
Doctor, what could be the reason for this faster progression in pseudo exfoliation? What are the possibilities? Why do you get faster progression?
Because there is pseudoexfoliative material development leads to increased IOP, and it also has systemic effects.
The reason, because you told PYAG progression is comparatively less compared to exfoliation, pseudo exfoliation. Any specific reason for that progression? Because everyone knows that secondary, as you told, no, secondary glaucomas are notorious. Okay. You are a PG, no? What is true exfoliation? You are told pseudo. What is true exfoliation? In which case you can have true exfoliation? You know, that is, hello, glass blower cataract. Glass blower cataract, infrared radiations can produce changes in the capsule. That is called true exfoliation. You should know this. Okay. Good, thank you.
The next presenter is Dr. Parvati S. Nair.
Good morning, everyone. My paper is on clinical profile of anisometropic amblyopia and its outcomes to treatment. Amblyopia is defined as the reduction of visual acuity in one or both eyes by abnormal binocular interaction during the critical period of visual development. So it's clinically defined as the difference of 2 lines or more in a visual acuity table. And the incidence of amblyopia in India, according to a population-based study, was 1.1 to 2.5%, and in tertiary eye care was 11.4%. There are different types of amblyopia. Among them, most common is the anisometropic amblyopia, and is defined as the difference of at least 1 diopter in refractive error between the 2 eyes. So, diagnosing amblyopia is very important because it is a silent cause of visual morbidity in children. The aim of our study was to assess the visual outcome to various treatment modalities in children aged 4 to 12 years with anisometropic amblyopia. It was a prospective study conducted in Tertiary Eye Care Institute among 139 children with a study period of 1 year, and the visual acuity before and after 6 months of treatment were statistically analyzed. The different modalities of treatment given were glasses, patching, and computer-based amblyopic exercises. We included children under the age group of 4 to 12 years with refractive error and anisometropic amblyopia. We excluded other types of amblyopia, children with squint, children with corneal pathologies, cataract pathologies, and retinal pathologies. So we could find that there was an equal distribution of male and female among our study population. And most of them belonged to the age group of 4 to 7 years. And we could see that most of them had mild amblyopia, then moderate amblyopia. And the most common type of refractive error that we encountered was astigmatism, followed by hypermetropia, then myopia, then compound myopic astigmatism. So among the 139 children, all of them were given glasses, And where options of patching and computer-based amblyopic exercises were given. 120 of them opted for patching, and 19 of them opted for computer-based exercises. And after 3 months of assessment, uh, we uh, s- we reviewed the patient, and 29 of them needed another mode of amblyopic exercise that was computer based, and 91 of them did not need any exercises, that is computer based exercises. We came to a result that there was statistically significant improvement in visual acuity in all categories, that is glasses with computer based, glasses with patching exercise, and glasses with patching and computer based exercises. And we could see that there was more improvement with glasses and computer based exercises than glasses with patching. So our study had a sample size of 139 children, while another study by Cabby et al. Included only 50 children, and Holmes et al. Was a meta-analysis study, included 996 children. The age group of all the studies were similar, and the follow-up was also similar, that is 6 months. We studied only an isometropic amblyopia, while Cabby et al. And Holmes et al. Studied all types of amblyopia. And the treatment modalities that we included were glasses, patching, and computer-based, while Cabby et al. Included patching and atropine, and Holmes et al. Include patching, atropine, and Baumgartner filter. All of the study concluded that there was visual acuity improvement in all the treatment, while Cabby et al. Also found that atropine was effective as patching, and Holmes et al. Concluded that amblyopia was more responsive to treatment in younger than 7 years of age. From our study, we could see that the astigmatism was the most common refractive error, and glasses along with amblyopic exercises showed faster improvement than glasses with patching. So amblyopia is one of the leading cause of childhood blindness. Early and standardized amblyopia screening is thus needed, as an isometropia can be asymptomatic. Regular follow-up was a crucial part of the treatment, and urgent intervention is of paramount importance to prevent irreversible and lifelong visual morbidity. These are my references. Thank you.
In these 6 months, how frequently did you, were the patient called back for review?
3 months review.
Every 3 months.
Yeah.
What was the line improvement at the end of 3 months?
About 1 to 2 line improvement in visual acuity was seen.
1 to 2 line. Along with this, was the stereopsis also reassessed at the beginning and at the end of 6 months?
At the beginning, it was assessed, but at the end, we did not assess.
You have done conventional occlusion, no? You
Sorry,
have done conventional occlusion.
Yes, sir.
That is normal eye occluded.
Normal eye occluded.
Do you have any formula for that? That is how many days you have to wear as per age. Your patients are what age patients?
4 to 12 years of age.
4 to 12. How many days you have given permanent occlusion for the normal eye? That is occlusion. And then how many days you have to occlude the amblyopia also?
Until the refractive error becomes, until the best corrected vision becomes 6.
Okay. Can I ask one question? That is, what is inverse occlusion?
Following occlusion of the normal eye.
Inverse occlusion. When will you do inverse occlusion? Because we are preparing for exam. Imagine I have come as an examiner for you. I am asking this question. Where will you apply inverse occlusion? No. That means in cases of eccentric fixations, you have to occlude the eccentric eye to remove the eccentric point. Then afterwards, you have to stimulate the macula of that eye with after images test. That is called pleoptics. Have you heard about pleoptics?
No, sir.
P-L-E-O-P. Pleoptics you have not heard. Pleoptics means eccentric occlusion, eye cover and then remove the eccentric point, then you stimulate the macula. These are all some of the short notes you get. Squint.
Okay, sir. Thank you.
Original crux is that anisometropia.
Yes, sir.
We aren't sure how much of anisometropia was there in your study group. How much difference between each eye and how much of correction was forced upon them. Those things also should be given. That should be said because you are stressing more on the amblyopia treatment than anisometropia treatment. We presume that from your study that you have pakka corrected anisometropia and not to amblyopia treatment. But your study, if you publish somewhere, will also need data on that.
Okay, sir. Thank you, sir.
The next speaker is Dr. Yasser Arafat.
Good morning. My topic is comparison of keratometric parameters from anterior segment OCT topographer and anterior segment OCT based biometry device keratoconus. My aim and objectives are to compare the anterior corneal keratometry values obtained from anterior segment OCT based topographer, that is Atlas Visande OCT, and anterior segment OCT based biometry device, that is IOL Master 700 in keratoconus. My materials and methods are: it is done as cross-sectional study. It was done at Comtrust Charitable Trust Eye Hospital with a population of 62 patients with keratoconus, and the time frame was 6 months. Inclusion criteria: patients coming to the OPD with keratoconus. Exclusion criteria include eyes with stromal scarring, history of corneal eye drops, history of corneal surgery including collagen cross-linking, and the patients having dry eye. The consent was obtained and detailed patient history was recorded. Basic ophthalmologic evaluations was performed. The consecutive corneal topography from Atlas Visande OCT and the biometry from IOL Master 700 was done. The four keratometric readings. So these were the measurements using both the machines. In the first machine, Visande OCT, simulated steep K and flat K was taken from 3 mm and 4.5 mm area. And from the IOL Master 700, total TK1, TK2 and K1 and K2 were taken. And these were compared. Statistical analysis include the test of normality of these parameters was analyzed using Shapiro-Wilk test, which suggested that these parameters were not normally distributed. So hence, to compare between the individual parameters, Wilcoxon's sign rank test was utilized. The correlation between the keratometric values were done using Spearman's rank correlation, scatter plots, heat maps, and the agreement between methods was done using Bland-Altman analysis and rain cloud plot. Observations and results. The study analyzed the data from a total of 123 eyes of 62 patients. The mean age of the participants was 24.59 plus or minus 5.07 years, ranging from 18 to 35 years. The analysis of individual factors. The mean TK2 value from the IOL master was 49.54 plus or minus 4.55, while the corresponding value from the Atlas 4.5 steep K was slightly higher at 49.57 plus or minus 4.30. So a Wilcoxon sign rank test was test confirmed that there was no statistically significant difference between these measurements. We can see that the p-value is more than 0.05, suggesting that the both modalities they provide comparable readings. Spearman's correlations also shows there was a strong positive correlation between all the variables, but very strong positive correlation was noted for 4.5 steep K and the DK2 value. Scatter plots also showed the strong relation between them, with more strong relation between the IOL master TK2 and Atlas 4.5 steep K values. Heat map, this also shows that there is a strong more correlation between the IOL master TK2 and Atlas 4.5 steep K. Bland-Altman analysis was performed separately for Atlas K and IOL master, and Atlas 4.5 K and IOL master, both for steep and flat K values. The mean difference on comparing these TK2 value from the IOL to the corresponding Atlas 4.5 steep K measurement was only 0.033, which shows that it is a narrow limit of agreement, suggesting that there is a stronger agreement between these readings. The first one is the bland Altman plot, and the second one is the rain cloud plot showing Atlas 4.5 steep can compared to IOL Master TK2. My conclusions are our study established that IOL Master and Atlas Topographer can be regarded as interchangeable for routine clinical assessments of corneal curvature, but strong agreement between the machines were observed for IOL Master TK and Atlas 4.5 values. This findings holds considerable importance for the preoperative planning in refractive and cataract surgeries, providing clinicians with the flexibility to choose between these devices while ensuring accurate measurements. Limitations are increasing the sample size could enhance the statistical analysis and improve the correlation between the two machines. When scanning larger areas, variations in values between the different machines may arise, potentially reducing the accuracy of the data. The difference in the values and correlations are more likely when measuring high refractive values, such as in cases involving severe astigmatism or ectatic disorders. Recommendations are that the topographer and IOL Master 700 can be utilized interchangeably for clinical assessments of corneal curvature. However, the 4.5 mm central zone provides a more accurate representation of the corneal curvature. Machine learning techniques hold transformative potential in this domain. These are my references. Thank you.
One is always available, even with the general ophthalmologist. The IOL master is available even with the general ophthalmologist. The other is usually available with the cornea departments. So in that context, when we look at, I believe that trying to look at whether this is good or that is good, we can as well double check with both when you are going to intervene on these high astigmatic cases or keratoconus cases. Then these values are getting double checked by these two machines. Otherwise, there is no scope for changes in those measurements. What made you first to design these two machines as a comparative? Why did you want to compare these two machines? What made you think that when you compare two machines, it should be like either the principle by which the machine checks are different. For example, if I look at plateau iris patients and study UBM diagnosis of plateau iris and anterior segment OCT diagnosis of plateau iris, that is acceptable because they are working on different principles. But here I think that clarity is not there. It looks like a random comparison of two machines just because you had those two machines and you wanted to compare that data. That way it is good, but what implication it has to another person who listens to that study, I'm not sure.
Now I'm happy because at least one male candidate has come. Okay. Yes, sir. Yes, sir, Afrat. No.
Yeah, yes, sir. Yes, sir.
But there is no extra mark for that. Please remember this. The thing is what your slides, letters and all, no, actually PowerPoint is should be visible from this distance. Actually, I'm not able to see some of the letters, something very small size. Because the slides also carry marks. Preparation of slides and all carry marks. Then you told now Shaprowak test. Do you know what is that and all? In examination, suppose you are going to present a presentation and you will say as per Shaprowak test. Suppose I ask you, what do you mean by Dr. Shaprowak test? You must be able to explain.
It is done to look for the distribution of the variable.
Please now, you can tell anything because I do not know about Shaprowak test. Please, it doesn't matter. Nothing wrong. At least in examination, be careful, okay? But examination, you cannot ask the examiner. You tell me, is it possible? Impossible to ask. Okay. But now whatever you want to tell, before that you prepare yourself and go.
Okay.
Okay. Nice. Thank you, Ma.
Okay, thank you.
So next one, Dr. Aisha K.
Good morning, all.
My topic is on anterior segment changes and complications following combined cataract surgery with vitrectomy. Globally, cataract remains the leading cause of blindness. Incidence and progression of cataract are higher in patients with diabetes. After vitrectomy, patients are at a higher risk for cataract progression. So, for patients who required cataract surgery and VR surgery, we wanted to evaluate the safety and efficacy of combined procedure in such patients. Aim of our study was to evaluate anterior segment changes of combined cataract surgery with vitrectomy in patients with significant cataract and diabetic retinopathy. It was a prospective study conducted at a tertiary eye care center over a period of 14 months in 63 eyes of 59 patients diagnosed with diabetic retinopathy and coexisting cataract. All patients with glaucoma were excluded. Preoperative assessment includes clinical profiling included detailed demographics and grade of cataract and grade of diabetic retinopathy. A clear corneal phacoemulsification followed by foldable hydrophobic intraocular lens implantation preceded all vitreoretinal surgeries performed by multiple surgeons. Postoperatively, patients were evaluated at day 1, week 1 and after 3 months, included corneal edema, corneal epithelial defect, AC reaction, intraocular pressure, hyphema, wound leak and IOL decentration. Coming to result, the mean age of the study participants was 60.7 years, which is consistent with the typical age of cataract surgery in diabetic patients. The average duration of diabetes was 17.7 years, showing that most participants had long-standing diabetes, which increases the risk of retinopathy. The mean RBS was 180.5 mg per deciliter and mean HbA1c was 7.6%, indicating that the majority had suboptimal glycemic control, a key risk factor for advanced diabetic retinopathy and surgical complications. Males formed 61.9% of the study population, while females were 38.1%. This suggests a male predominance in the patient pool. The most common cataract type was nuclear sclerosis grade 2, followed by posterior subcapsular cataract and cortical cataract. A smaller proportion had nuclear sclerosis grade 1 and only 1.6% had nuclear sclerosis grade 3. The majority of patients had advanced proliferative diabetic retinopathy followed by high-risk PDR. Early PDR and non-proliferative diabetic retinopathy were much less frequent. In non-proliferative diabetic retinopathy eyes, the main indications were epiretinal membrane and vitreomacular traction. In proliferative diabetic retinopathy eyes, the commonest indications were vitreous hemorrhage and tractional retinal detachment, followed by macular traction and combined retinal detachment. Silicon oil tamponade was done in 47 eyes, while it was not required in 16 eyes. The corneal epithelium was intact in 56 eyes, whereas in 7 eyes, due to prolonged VR surgery, media became hazy, so epithelial scraping was done. Corneal edema was present in 14%, and it was transient and resolved completely by the first postoperative week. 12% of eyes had raised intraocular pressure on day 1, but by 1 week, all eyes had normal intraocular pressure with one anti-glaucoma medication. Silicon oil tamponade was done in these patients during VR procedure. Postoperative anterior chamber inflammation was found mild in 95% cases and moderate in 5% cases. No cases of wound leak, hypotony, hyphema or IOL decentration were encountered. Coming to discussion, our study was a prospective study conducted in 63 eyes of 59 patients with a follow-up of 3 months. Found elevated IOP in 12%, corneal epithelial defect in 11% and corneal edema in 14%. In a similar study conducted by Quinn Xiang Zheng et al. In 285 eyes of 238 patients with a follow-up 6 to 72 months, found posterior capsular opacification in 50 eyes and corneal edema in 11.2 percentage and elevated intraocular pressure in 10.8 percentage. Another study by Cannon et al. Was a retrospective study with a follow-up of 6 to 48 months, found IOP elevated in 25 eyes, corneal edema in 5 eyes, and corneal epithelial defect in 6 eyes. To conclude, combined phacoemulsification and vitrectomy is more convenient, avoiding 2 separate sessions and involves no additional postoperative complications. It provides a clear media for better visualization of the fundus. As cataract progression is a complication of vitrectomy, combined surgery is beneficial. It provides quicker visual rehabilitation. It's convenient for the patient to undergo surgeries in one sitting in terms of post-op rest and medications which are not repeated. Overall, patient stay in operation theatre and hospital is reduced. It is also economical for the patient as the surgeries are combined. These are my references. Thank you.
Whatever you try to evaluate are a given no. Phacovitrectomy, the whole community has accepted. There is very few people who today do staged cataract and vitrectomies. And the second is looking at anterior segment variables like how much corneal edema happens and how much seem to be very trivial. They don't like if you have said like how complete the vitrectomy is, how much that visualization after post cataract surgery IOL helped the vitreous procedure would have been more relevant. Second point. Third point is all these patients long surgeries is taken for granted. Surely it will be long surgery. So you are just trying to echo whatever is already accepted dictums in vitreoretinal surgeons parlance. So that way you will not design a study. If you design a study, there should be some research question there. That question needs answer. Here I don't see any research question. It's just like you are trying to amplify whatever is already accepted and trying to say that that is it, that is it, that is it. Like that you are saying. If you have worked on surgical time, if you have worked on whether you gave whether an anti-VEGF prior to the surgery helped or not in a staged surgery, or if you have actually compared stage surgery and phacovitrectomies, I think you would have had better results. The way it looks. Okay, try to do that. Thanks.
You've done some epithelial scraping, some of the patients. Why did you do that? Because of course edema is there. Why do you want to remove the epithelium alone?
For better visualization of fundus.
No, why that epithelium was removed? You told the media is easy because of edema of the cornea. I have removed the epithelium. What's the rationale of removing epithelium? It's an exam question, please remember. Where is the maximum edema getting collected, fluids? In the cornea, in which layer edema is getting collected? Maximum. Stroma. Then why do you want to remove the epithelium then?
Epithelium.
Because when you remove the epithelium, it became clear, I told. That means edema should have been there. Okay, instead will ask you, oh, you should have applied something, glycerol, glycerin or something, or you can have hypertonic saline, all you can use even to remove the epithelium or remove to reduce the edema. Okay, these are some of the questions we may ask in exam, not here. This destination because you are told about epithelial scraping. So we want to assess you whether you know something about that. So, okay, thank you.
Cataract NS1. With the NS1, the media must have been relatively much clearer. Vitrectomy should not have been a problem. So why in that case a combined procedure was opted? Other cataracts, yes. Why NS1?
It mainly depends on patient.
So the study also include patient's preference too?
Yes, ma'am.
Next presenter is Dr. Grishma Marin Sebastian.
Good morning. My topic is Comparative Study Magnocellular Stimulation versus Occlusion Therapy, a prospective case control study in amblyopia treatment. Amblyopia is a developmental disorder of spatial vision affecting 2 to 5% of the global population, where the current gold standard treatment is occlusion therapy, that is patching of the dominant eye to stimulate the amblyopic eye, where the success rates were seen to be 50 to 75%. And the major limitations of current therapy included treatment adherence, psychological impacts, and practical difficulties when the amblyopic eye vision is severely reduced. Coming to the magnocellular stimulation, which is a new approach. Dr. Santan Gopal et al. He has introduced an orthoptic magnocellular stimulator, which was based on the magnocellular stimulation, and his results showed that there was 64% improvement in visual acuity and 97% in stereo acuity. So this is based on the saccadic movement, which was confirmed by Peterson SE et al. That is, maximum foveal stimulation occurs during the initiation of the saccades, which he studied using a series of 5 positron emission tomography experiments. Coming to the occlusion pathway, that is major pathway of occlusion, parvocellular pathway. Here, when the light reaches the fovea and the information is passed through the lateral geniculate nucleus and to the primary visual cortex 4C beta area where the foveal stimulation occurs. And in our orthoptic device, that is the magnocellular pathway. Whenever the reflex saccades initiates, the information is passed to the lateral geniculate nucleus of area 1 and 2, and from there it is again conveyed to the primary visual cortex, and that is the 4C alpha area of the primary visual cortex, and from there the impulse is again further processed to the posterior parietal cortex, and information from the frontal eye field and posterior parietal cortex through the top to down impulses reaches back to the primary visual cortex, and which causes the foveal stimulation. Now, aim and objective is to study and compare improvement in visual acuity with magnocellular stimulator and occlusion therapy in the management of amblyopia. Secondary objective is to see the improvement in stereopsis. It was a hospital-based randomized prospective case control study, and the patients were diagnosed with amblyopia attending the pediatric ophthalmology clinic from May 2023 to November 2024 was included. Amblyopic children of age group 5 to 12 years and refractive amblyopia, strabismic amblyopia, and best corrected visual acuity less than or equal to 6/12 and also not those children not undergone occlusion therapy in the past 6 months were included in the study. Defective vision due to trauma to eyes, deprivation amblyopia, defective vision due to retinal pathologies and optic nerve pathologies were excluded from the study. The target population of 81, that is 41 in the occlusion group and 40 in the orthoptic group of age group 5 to 12 years with confirmed amblyopia attending the pediatric ophthalmology clinic were taken for the study. Consecutive sampling done, and they were divided alternatively into both the groups. Snellen visual acuity values recorded and was converted to their corresponding logMAR values. Stereo acuity was measured using TNO test wearing red-green goggles and graded. Now, occlusion therapy protocol, which was based on the pediatric eye disease investigator group guidelines, 2 hours daily patching were advised, which was monitored by parents. Magnocellular stimulation protocol, the orthoptic device protocol involved a 30-minute structured 2 programs with LED light tracking exercises. It had 2 programs with each having uniocular movement 800 times and binocularly 500 times. Total duration was 7 months, which included a total of 17 sessions, and the follow-up was done at the end of 1, 3, 5, and 7 months for the parameters of best corrected visual acuity and stereo acuity. Now, 41 eyes in the occlusion group and 40 eyes in orthoptic group with amblyopia of age 5 to 12 years were included in the study, and the study was statistically analysis was done by a statistician. Now, assessment of change of the best corrected visual acuity at different time points in the occlusion group showed that significant and consistent improvement in visual acuity from baseline, and that of the orthoptic group showed that also showed significant and consistent improvement in visual acuity from baseline. Now, comparison of the best corrected visual acuity between both groups showed that at 1 month, orthoptic group had a statistically significant improvement over the occlusion group. Beyond 1 month, both the groups continued to improve, but the difference between them was not statistically significant. Now, change of stereo acuity from baseline at different time points in both groups showed that occlusion group had a gradual improvement in stereo acuity, and the orthoptic group had a more rapid and significant improvement in stereo acuity. Now, comparison of the stereo acuity between 2 groups, the improvement in stereo acuity observed in the orthoptic group was found to be statistically significant compared to the occlusion group. The study was done to compare benefits of orthoptic magnocellular stimulation with occlusion therapy in children with amblyopia in the age group of 5 to 12 years. And the percentage children having improvement in visual acuity in our study was 87.8% with the occlusion group and 85% with the orthoptic group. Now, the percentage of children having improvement in stereo acuity was seen to be 77.5% with the orthoptic group and 29.3% with the occlusion group. So at 1 month, orthoptic groups showed a statistically significant improvement over the occlusion group, but at 7 months, both groups showed almost similar improvement, that is 87.8% in the occlusion and 85% in the orthoptic. Now, a substantial improvement in stereo acuity was found in the orthoptic group throughout the study, that is 77.5% for orthoptic and 29.3% for occlusion. The superior stereo acuity outcome in the orthoptic group is attributed to the binocular approach of the therapy and higher compliance as each session done and monitored at hospital. Now, strength of the study, no other similar comparative study available in literature and able to monitor at hospital. Limitations, difficulty to recruit children as they have to come to hospital for sessions, small sample size and follow-up time was limited. So to conclude, the improvement in visual acuity in orthoptic group was higher in the first month, though at the end of 7 months was almost similar in both the groups. Stereo acuity improved in both groups, but the improvement seen in orthoptic group was very significant, that is 77.5% when compared to occlusion group, that is 29.3%. So our recommendations are increasing the frequency of sessions in the orthoptic group over the last 4 months could have led to better improvement, and longer follow-up is necessary to evaluate regression of vision after stopping the treatment. Thank you.
What type of amblyopia? The denser the amblyopia, then outcomes change. Yes, that's no. So in an anisometropic variety, in a strabismic variety, in a sensory deprivation variety, how much of that initial cause for amblyopia affected your outcomes you haven't shown? That should be shown, point number one. Point number two, whether both have synergistic effect. Should somebody choose to do both orthoptic and occlusion, will it have a role? That also is not brought out. That also should be brought out. Okay?
Okay, sir.
The other practical aspect is the vision therapies are going to be they're going to include money, right?
Yes,
Apart,
ma'am.
so what do you charge in your institute?
That is, we charge as per a 7. This is total duration is 7 months, a total 17 sessions. So we are giving us a package in 10,000.
Okay, so all the parents are billing for it. Okay. Other thing was microtropia looked for. Microtropia is another unseen, undetected cause which is labeled as this amblyopia vaguely. Was that looked for specifically? I think unilateral amblyopias with subnormal vision, not very drastically reduced, please do a 4% base out. Okay, now you can also see to what extent these conditions also improve with occlusion therapy and with vision therapy.
Okay.
Okay, did you try, those patients with vision therapy, with occlusion alone, did you try switching them over to vision therapy after a few months? Because when you knew the stereops is much better in the vision therapy.
Oh, actually, we didn't try that, ma'am, because the study duration was only 7 months, so we didn't have enough time to do. In future, we can try to do.
The orthoptic, that is mainly for psychiatric moments you are checking, not pursuit and all. No need for that. Because your pathway you have shown, no something.
Yes, sir.
Huh?
Yes, sir.
From something for the pathway. That is for pursuiters, psychiatrists.
It's magnocellular.
Magnocellular, that is mainly for movements, you know that. What the color vision pathway? What's the other pathway in the
Parvocellular.
parvocellular pathway?
Yes, sir.
Do you know, for fun gang, I'm asking, what is coniocellular pathway? KONIO. You have not heard, but you are using that, you know that. See, in glaucoma, you are using yellow-blue, no?
Yes, sir.
That yellow-blue to find out the early problems.
Yes, sir.
That pathway mainly concerned with conio cells, that in the LGB.
Yes, sir.
So when it get affected, the early glaucoma you are telling. That's what you are using a swab.
Yes, sir.
Short wave like the automatic perimeter, you know, that is called swab. You are using yellow and blue. That is based on conio cells.
Okay, sir.
You have not heard.
Heard.
Last question. Because it is my way of asking questions. Hello. What is amblyopia of misuse? Of course, I am not bothered about this paper, no. Yes, most of the papers, you know. But amblyopia, at least before you go, you must know something. Amblyopia of misuse. Don't know. Amblyopia of disuse. No. You're supposed to know all these things. Amblyopia, exanopsia. Don't get frightened now, please. Misuse means the patient gets developing diplopia. Because of that, the one eye is going for suppression. That is called misuse. Eye is normally for binocular vision. So natural diplopia is the misuse. Disuse means we have got ptosis, congenital ptosis. There is no sensation. That's called disuse. Eye is not used. That's all. That's called disuse and misuse. There are some other terminologies, of course, olden days term. Now no, nobody will read. But I studied. No, I have to tell. Thank you.
The next one is Dr. Sanju Shankar.
Good morning. I'm discussing human ocular dirophyllariasis and emerging zoonosis in the eye. Myself, Dr. Sanju Shankar. Dirophyllariasis is an emerging zoonosis which is endemic to South Kerala, and it is really a concern, and that is the reason why I am here today with this topic. It is being caused by the genus Dirophyllaria, of which the most common are Dirophyllaria repens and Dirophyllaria immitis, and it is being transmitted by female mosquito vectors, and this is a life cycle of Dirophyllaria repens which is notable to cause the ocular lesions. Now, the reservoir hosts are the dogs from where the disease is being transmitted by the female mosquito vectors to humans who are the dead end host. And in our area, there are various factors which is contributing to the growth of the vector population, which include natural water sources, humid climate, rainfall, heat islands, and stray dogs. Aim of my study is to analyze demographics, identify varying clinical presentation, management approaches, and treatment outcomes. Mine was a retrospective study of 33 patients with ocular dirophyllariasis conducted at a single tertiary eye care center in Kerala of duration 8 years, and all patients presenting with acute ocular inflammation associated with itching and radiologically confirmed with a cystic mass was included in the study, and patients with loss follow-up being excluded. On analysis, out of the 33 patient study, 55% were females and 45% males, and the age of presentation ranged from 2 years to 88 years with a median age of 46 years, and all the 33 patients had a unilateral involvement. And the clinical presentation, the commonest symptom was acute onset eyelid swelling along with itching with associated pain, and the duration of disease ranged from 2 weeks to 8 months. According to the anatomical distribution, 55% had an eyelid involvement, 39% with orbital involvement, and 6% with conjunctival involvement. On clinical examination, the most common sign that was elicited was a palpable mass, followed by lid edema, congestion, chemosis, proptosis, and preseptal cellulitis. And the image in the right end, it is a case which presented only with a palpable mass without any signs of inflammation. And all those whom we had a clinical suspicion was sent for an imaging technique, which include an ultrasound B scan, which revealed a cystic swelling with a serpiginous structure with parallel echogenic walls and an echoic lumen, giving a tram track appearance, and an MRI orbit, which showed in T1 weighted MRI hyperintense well circumscribed rim with a hypointense score, and as in the image T2 weighted MRI well encapsulated hyperintense lesion with a hypointense rim. An MRI was used to assess the plane of involvement and exclude other abnormalities. And all the 33 patients, we started initially on medical management of tab prednisolone 1 milligram per kilogram body weight per day, tapered over 5 days, and tab albendazole 15 milligram per kilogram body weight in 2 divided doses, along with other symptomatic management. The treatment outcome out of the 33 patients, all were given initially medical management, of which 85% had complete cure, and they were sequentially followed up, while remaining 15% they had a persistence, either progression, recurrence, or a visible worm mass, which is an indication for surgical management. In surgical management, we did a surgical excision for which 60% underwent the eyelid lesion excision, 20% anterior orbitotomy, and 20% conjunctival lesion excision was done. And all the patients who underwent the surgical excision, the specimen was sent for a microbiology and histopathological analysis, which revealed a pseudocystic cavity surrounded by a fibrous capsule and an intense inflammatory cell infiltrate. The cavity contains sections of the nematode characterized by thick multilayered cuticle, as shown in the image. the follow-up and cure rates. At the end of 1 month, we had 55% of the patients with complete cure. At the end of 2 months, 85%. And at the end of 3 months, all patients had complete cure of the disease. And this was a case, a 2-year-old child who was the youngest among our patient series, who presented with a lesion in the anterior orbit along with severe itching and proptosis for more than 6 months duration. She was referred from elsewhere. A patient was already on ivermectin and steroids, and on clinical suspicion, we sent her for an imaging technique. MRI orbit revealed a worm mass within the superior rectus and LPS complex. And due to the persistence of the disease, we did a anterior orbital exploration, and the worm mass along with the cyst was excised with a maximum complete preservation of the superior rectus and the LPS complex. So to conclude, Kerala is an endemic area for ocular dyrophyllariasis. It is a diagnostic challenge due to its varied clinical presentation. Clinical suspicion with imaging is a pointer to diagnosis. Treatment outcome is excellent with medical management. Surgical excision for persistent cases, and those complete surgical removal offered negligible recurrence. So how to control? Strengthening awareness among clinicians, public health measures aimed at vector control, prevention of misdiagnosis, and a control of stray dog population. These are my references. Thank you.
A filarial worm that is reachable should be surely reached and removed. No.
No.
That medical treatment which you gave,
Yes, sir.
where in which instances did you give medical treatment? Where were the microfilaria?
Majority of the patients, that is in 55% of the patients, they had an eyelid mass, while remaining 39%, they came with an orbital.
So those eyelid masses, you just gave medications and they became all right.
Yes, sir. Initially, we were given medical, the patients were given medical management, that is tab albendazole along with prednisolone, and almost 85% of them had complete cure, that is, they were devoid of the disease.
And the mass stayed, no? The mass regressed.
Yes, sir, mass regressed completely.
Oh, surprising. I believe that once a worm is lodged somewhere, no other choice but to remove it. But I'm not sure whether you'll give a medication, allow it to die and stay there forever. Then surely it will create a foreign body reaction.
So for conjunctival visible worm masses, we directly did a surgical excision, while the other eyelid masses, we initially gave the medical management and we waited. If it was persisting or if there was a recurrence, then we did a surgical excision.
Okay. How many, in your series, how many cases now you have?
33 patients were studied.
33 patients. And those patients, anytime you saw recurrence?
No, sir. We only 5 patients we did a surgical excision, and we sequentially followed them after 1 month, 2 months, and 3 months. After 3 months, almost all the patients had complete cure. Until now, they didn't have any recurrence. The patient didn't come back to us with recurrence.
Any patient needed steroids then?
Yes, sir. The steroid was given along with anti-helmintic. All patients.
Anywhere you saw these filaria lodged elsewhere in other systems? ENT
No.
systems?
No, sir.
CNS?
No, sir.
Why Kerala is very common, you told, no? Endemic something.
So there are various factors which is favoring the growth of the vector, that is a mosquito, that is humid climate, then abundant rainfall, then even stray dog population, as the dogs are considered to be the reservoir host. It is also a contributory factor to promote the disease.
What about the lungs involvement? Because he told about ENT and all. No?
Yes.
What about the lungs? Commonly the lungs are getting infected, or cardiac, heart and all may be infected.
Yes, sir. It also causes a pulmonary involvement, but in our study group, we didn't find any other
You have checked?
Sir?
You have taken all the
Yes, sir.
investigations?
Yes, sir. We didn't find any other systemic involvement of the parasite.
Oh. You have tried only ivermectin.
No, sir. According to our hospital policy, we didn't give ivermectin to a single patient. And as I showed, the baby, she was given ivermectin, and due to persistence, we started on surgical management. So, we
Do
didn't.
you know some other filarial worm which can produce blindness, river blindness?
Cysticercosis.
Cysticercosis. Hello. Filarial, which can produce onchocerca volvulus, transmitted by
Onchocerca volvulus.
transmitted by. You don't know, it's a fly, Simurium black fly. You should know all these things because that onchocerciasis is included under 2020 program when WHO introduced.
Okay, sir.
Okay, India we do not have agreed, but you should know something about the WHO programs which were included
Okay.
as a PG.
Okay, sir.
Last question, can you answer? What is Wolbachia? Wolbachia. Wolbachia.
Sorry, sir.
You tell correctly, I will tell Shankar Netralaya madam to donate you 10,000 rupees. Now she is very rich, hello. You don't know, Wolbachia is a rickets that is on the surface of onchocerca, normally resides. It's a actually, a mutual understanding between them, symbiotic life. Now, when you're treating filariasis, that river blindness case, you are giving ivermectinol, whatever thing is there. In addition, you have to give antibiotics also, because to overcome this Wolbachia is a antibiotic to be given. You know the reason. Wolbachia helps in reproduction of your onchocerca. If the Wolbachia is killed, actually they cannot reproduce. That's the way for control of that. In addition to ivermectin, they give antibiotics also. Just know this.
Okay, sir.
Okay.
Okay, sir.
Thank you very much.
Thank you, sir.
Curiosity, just like how in tuberculosis we can expect a delayed autoimmune reaction decades later. Can we expect such kind of autoimmune reaction in these patients too? I mean, your study was 8 years, none of them had a recurrence up, but can it be expected?
It causes usually a local inflammatory reaction.
Okay, so there's no systemic manifestation, just like how neurocystic cirrhosis can be anywhere.
Yes.
This worm can is it only localized? It can also be anywhere, right? So should you have a periodic follow of such patients?
Yes, ma'am.
Should we consider giving them a medical card, telling them anything to do, any inflammation, fever,
Yes,
anything? They
we have
should carry this with
advised the
them?
patient that if there is any inflammation or any symptoms which is being persisting, or if it is recurring, then to follow up immediately.
Recurrence in what term? Was it again it's a worm or again as a asthma it's an autoimmune reaction? A delayed autoimmune reaction.
Any inflammatory process in the body, if it is recurring, then the patient has to be followed up. Thank you.